Welcome to this deep dive. If you are joining us today, you are likely here because you need to understand the really intricate, sometimes baffling, and always fascinating world of forensic pathology, specifically when it comes to natural deaths.
Right.
And our mission for this analysis is clear. We are going to build a robust conceptual framework for understanding how forensic pathologists approach deaths that are caused by disease rather than violence. We want to help you map out the mechanisms, the injuries, and the profound medical-legal implications of these cases.
Yeah, it's a huge topic.
It really is. And just to set the stage, this is designed as a high-yield, memory-anchored companion to Chapter 6 of Simpson's Forensic Medicine. It's a conceptual exploration meant to support your reading of the text, not a replacement for it. So grab your book, keep your resources handy, and let's get into the mechanics of when the body simply, when it simply powers down.
The central challenge in these cases is untangling whether a system failure was truly natural or if something darker was at play. It requires a tremendous amount of discipline to look at a body with absolutely no external injuries and meticulously prove a natural cause of death. You are often fighting against assumptions, both from the medical community and from law enforcement.
Absolutely. And actually, I want to start with a statistic from the source material that completely shatters one of our most basic assumptions. When someone dies, a doctor signs a death certificate, and we tend to view that piece of paper as the absolute, unquestionable truth.
Right.
But the data shows that in 25 to 60% of deaths, there are significant differences between what the clinician presumed was the cause of death and what is actually found if an autopsy is performed. Up to a 60% error rate on the presumed cause. I mean, that is a massive illusion of certainty.
It really forces us to treat raw epidemiological data, the stuff based purely on death certificates, with a high degree of caution. If you're looking at broad public health statistics to determine resource allocation, you have to remember the shaky foundation those statistics might be built upon.
Because it's not always a perfect science on the ward.
Exactly. And the underlying reason for this high discrepancy rate isn't necessarily medical incompetence on a personal level. It's a systemic issue. In many busy hospital environments, the administrative task of certifying the cause of death is often delegated to junior staff.
The ones with the least experience.
Exactly. You have doctors with the least amount of clinical experience suddenly tasked with making a definitive legal declaration about a complex multi-system physiological cascade that resulted in death. They're making their best educated guess based on the patient's final days, but without looking inside, it remains a guess.
I know different jurisdictions have recognized this structural flaw and are attempting to solve it in varying ways. For instance, the source material contrasts the approaches in England and Wales with the system in Scotland.
Right, they took quite different paths.
Yeah. In England and Wales, they've been implementing a medical examiner system. The core philosophy there is adding a layer of experienced, independent oversight. Deaths are scrutinized by senior doctors who weren't involved in the patient's direct care. These senior physicians consult with the attending doctors on the precise wording used on the medical certificate of cause of death, and they also discuss any concerns directly with the bereaved relatives. It acts as a real-time quality control check.
And Scotland took a slightly different structural approach by establishing the Death Certification Review Service. Instead of reviewing every single death, they employ a randomized sampling method.
Okay, so a percentage.
Right. They pull a percentage of certificates and review them rigorously. Their goal is dual purpose. Yes, to improve the immediate accuracy of the certificates, but more importantly, to gather highly accurate, verified data about causes of death so that the National Health Services can accurately plan for the future. It operates essentially as an epidemiological safeguard.
That makes a lot of sense. Speaking of precise medical legal wording, we need to clarify some terminology before we start looking at specific organ systems. When we discuss these rapid natural deaths, two words dominate the conversation: sudden and unexpected.
And they are definitely not the same thing.
Right. In casual conversation, we use them interchangeably, but in forensic medicine, words matter immensely. The World Health Organization defines a sudden death as one that occurs within 24 hours of the onset of symptoms.
That 24-hour window is a clinical definition. And for a forensic pathologist, 24 hours is an absolute eternity.
I can imagine.
In forensic practice, a sudden death usually means death occurred within minutes or even seconds of the onset of symptoms. The person was ostensibly fine, and then they collapsed. If a death is delayed by several hours, the patient has usually made it to an emergency department. A clinical diagnosis has likely been established through blood work or imaging, and the case won't even be referred to a medical legal authority. Forensics is primarily concerned with those blink-of-an-eye tragedies.
It's a great distinction. And it's fascinating how sudden and unexpected are not mutually exclusive, nor do they always overlap. Someone could develop a mysterious, slow-progressing illness over 3 months that ultimately kills them unexpectedly, but not suddenly.
Exactly.
Conversely, think of a patient with severe end-stage heart failure who passes away in seconds. The death is sudden, but given their pathology, it is entirely expected.
The trigger for our system occurs when you combine the two. When a death is both sudden happening in minutes or seconds and entirely unexpected given the person's known medical history, that combination mandates a medico-legal investigation. The state has an obligation to figure out exactly what happened to ensure there was no foul play, industrial hazard, or infectious outbreak.
So let's transition into the most common physiological culprit behind those sudden, unexpected events. We have to start with the cardiovascular system.
Yeah.
I find it helpful to conceptualize the heart in 2 distinct parts that can fail. The plumbing, meaning the blood vessels, and the pump, meaning the electrical and muscular tissue.
I like that.
Let's tackle the plumbing first. Coronary artery disease and the ischemic cascade.
This pathway is the absolute bread and butter of rapid natural death investigations. The mechanism almost always begins with atheroma, which is the gradual buildup of lipid-rich plaque within the walls of the coronary arteries. As this plaque grows, it causes stenosis, a physical narrowing of the vessel lumen. We can think of this in terms of simple fluid dynamics. Under normal resting conditions, a severely narrowed vessel might still allow just enough blood through it to keep the heart muscle alive. The supply meets the low baseline demand.
But the danger arises when that demand suddenly spikes. The person goes for a sprint to catch a bus, or eats a massive heavy meal which diverts blood to the gut, or experiences a sudden surge of catecholamines adrenaline from a heated argument or intense fear.
Right, the heart rate accelerates.
The heart rate accelerates, the heart muscle demands significantly more oxygen, but that stenotic plumbing simply cannot increase the flow. The demand vastly outpaces the supply, and the myocardium distal to that narrowing becomes ischemic. It's starved of oxygen.
And this leads to a critical forensic principle that is frequently misunderstood. Ischemia does not have to cause a full-blown myocardial infarction, meaning actual necrotic dead tissue, to be fatal.
That's a huge point.
The lack of oxygen causes the heart muscle cells to become electrically unstable long before they die. The cellular membranes fail to maintain their proper ion gradients. All it takes is for that localized oxygen starvation to trigger an abnormal electrical rhythm, a fatal arrhythmia like ventricular fibrillation. If the specific part of the heart rendered ischemic happens to encompass one of the pacemaking nodes, the risk of a lethal rhythm abnormality skyrockets. The individual drops dead instantaneously, and at autopsy, the tissue hasn't had the hours required to undergo necrosis. The heart muscle might look entirely viable to the naked eye, even though it just caused a fatal short circuit.
So the electrical grid fails because the plumbing got clogged. Let's look closer at those atheromatous plaques. They are not just static, hardened blockages like rust in an iron pipe. They are dynamic, highly dangerous biological structures. The source material outlines 3 primary ways these plaques complicate and turn a chronic condition into a sudden fatality.
The first complication is hemorrhage. The tiny blood vessels that feed the artery wall itself can rupture, causing a subintimal hemorrhage directly into the plaque. This sudden bleeding rapidly swells the plaque, acutely narrowing the lumen even further. You can often see this fresh hemorrhage during the macroscopic dissection of the coronary arteries.
And that's it.
The second complication is expansion or rupture of the plaque. The fibrous cap covering the atheroma can ulcerate. When it tears open, it extrudes a highly thrombogenic mix of liquid cholesterol, fat, and necrotic cellular debris straight down the artery, impacting distally and causing multiple microscopic infarctions.
The source material also describes a scenario where the torn endothelial cap of that ruptured plaque acts like a mechanical flap valve within the vessel. It literally catches the flowing blood and slams shut across the lumen, causing a total, instantaneous obstruction. It's a terrifying mechanical failure of your own anatomy.
Yeah, it really is. And the third, perhaps most common complication is thrombosis. Because the inner contents of a plaque are highly reactive, any ulceration immediately triggers the body's clotting cascade. A blood clot forms directly over the ruptured plaque, further reducing the lumen or blocking it entirely. Coronary thrombosis is the underlying pathology for unstable angina, acute infarction, and sudden cardiac death. However, it is vital to note that the frequency of actually finding these thrombi at autopsy varies wildly across different studies, ranging anywhere from 13 to 98%. Sometimes the clot breaks down after death, or it was a purely arrhythmic event without a full occlusion.
That variance highlights just how difficult the postmortem evaluation can be. But let's build out the timeline. Let's say the patient survives the initial ischemic event. They experience a true myocardial infarction. A portion of their heart muscle dies. They make it through the first 48 hours, and they might feel like they are out of the woods. But the textbook points out a literal physiological time bomb waiting in their chest.
The window of maximum vulnerability opens up a few days later. When the cardiac muscle tissue dies, it undergoes cellular necrosis. The body's immune system recognizes this dead tissue and mounts a massive inflammatory response to clean it up. Macrophages infiltrate the area to digest the necrotic cells. During this enzymatic cleanup process, the structural integrity of the myocardial wall is severely compromised.
It gets physically weak.
Incredibly weak. It becomes soft, often described pathologically as having the consistency of wet cardboard. The highest risk for this weakened myocardium to physically tear or rupture under the pressure of the pumping blood is between 3 days and 1 week post-infarct.
3 days to 1 week. That is a critical anchor for our listeners. And if that wall gives way, the mechanics of death are fascinating in a morbid sense. If the left ventricular wall tears, highly pressurized blood pumps completely out of the heart chamber. But it doesn't just fill the chest cavity. It is trapped by the pericardial sac, the tough, fibrous, double-walled bag that encases the heart.
Because that fibrous sac is relatively inelastic and cannot stretch quickly, the blood fills the confined space, creating a condition called hemopericardium. As the volume of blood increases, the pressure inside the sac rapidly rises, eventually exceeding the venous pressure trying to return blood to the heart. The accumulating blood literally crushes the heart from the outside.
It just suffocates it.
Right. The heart chambers can no longer expand during diastole to fill with blood. This catastrophic compression is called cardiac tamponade. Cardiac output plummets to zero, leading rapidly to cardiac arrest and death. Alternatively, instead of the outer wall, an infarcted papillary muscle, the internal muscular pillars that anchor the heart valves, might rupture. This causes the mitral valve to prolapse and flap wildly, leading to acute, overwhelming heart failure.
Moving from the plumbing to the sheer mass of the pump itself, evaluating the size and weight of the heart is a fundamental part of the autopsy. An average, healthy adult male heart weighs somewhere around 400 grams. But the textbook notes that any heart weighing over 500 grams is considered inherently electrically unstable. An enlarged heart essentially outgrows its own blood supply, creating a state of chronic myocardial hypoxia, which primes the electrical grid for a fatal arrhythmia.
It creates a massive oxygen demand that normal coronary arteries struggle to meet. The clinical differentiation here is vital, especially when comparing the enlarged heart of an elite athlete to the enlarged heart of someone with chronic hypertension. Both vigorous exercise and high blood pressure cause the heart to adapt by growing larger left ventricular hypertrophy, or LVH.
I always assumed athletic hearts and hypertensive hearts were functionally the same adaptation, just bigger muscles working harder. But the textbook points out a massive microscopic distinction. Fibrosis. How exactly does that interstitial scar tissue change the electrical game?
It changes everything. The cardiac remodeling resulting from chronic hypertension is a pathological process. The heart is pushing against high systemic resistance constantly. It features not just myocyte hypertrophy, larger muscle cells, but heavily involves the laying down of rigid collagen and scar tissue between those cells. This interstitial fibrosis stiffens the heart wall, impairs its ability to relax, and disrupts the electrical pathways, serving as a nidus for arrhythmias. Conversely, physiological LVH in athletes is a healthy proportional expansion of the capillary network alongside the muscle growth. It notably lacks that deadly, chaotic interstitial fibrosis. The pathologist can see this difference clearly under the microscope.
Before we move off the macroscopic structure of the heart, we need to touch on aortic stenosis. This is the most common form of valvular heart disease. It typically affects older demographics whose tricuspid aortic valves become rigid, fused, and heavily calcified over decades of wear and tear. Though you also see it in much younger individuals born with a congenital bicuspid aortic valve, 2 flaps instead of 3, which calcify much earlier in life.
Right. Because the valve is narrowed and stiff, the left ventricle has to generate massive pressures to force blood through it into the aorta. This chronic strain leads to some of the most extreme cases of left ventricular hypertrophy we see, with heart rates sometimes exceeding 700 grams.
And the physics behind why this is so deadly ties perfectly back to our plumbing analogy. Think about the Bernoulli principle in fluid dynamics. Because the blood is struggling to squeeze through that narrow, rigid opening, the pressure in the aorta immediately above the valve drops significantly. Unfortunately, that specific location, the aortic root, is exactly where the coronary osteae are located.
The tiny openings that feed the coronary arteries.
Exactly. So you have a massive 700-gram heart demanding vast amounts of oxygen. But the narrowed valve is actively dropping the pressure needed to perfuse the very arteries supplying that muscle. It is a physiological paradox and a perfect storm for sudden ischemic death.
To close out the macroscopic cardiac overview, we should briefly discuss the changes seen at the extreme end of the age spectrum. If you are conducting an autopsy on someone in their late 90s or hundreds, you look for senile myocardial degeneration. The heart takes on a very specific appearance. It is typically smaller than average, and the surface coronary vessels appear highly tortuous, twisted, and winding because the underlying heart muscle has shrunk away from them over time. The myocardium itself is often soft and takes on a distinct brown color.
That brown atrophy is due to the accumulation of lipofuscin. Think of lipofuscin as the cellular equivalent of rust on a machine that's been running continuously for 9 decades. It's an indigestible residue of lysosomal degradation, a wear and tear pigment that slowly builds up inside the myocytes over a long lifetime.
From those macroscopic visible changes, we must transition to the microscopic and the molecular. This brings us to primary diseases of the heart muscle, particularly relevant when investigating the sudden deaths of younger individuals. We divide these into conditions where you can identify a structural abnormality, either visually or microscopically, and conditions where the heart appears completely, perfectly normal.
Starting with the structural anomalies, let's look at myocarditis. This is an inflammation of the heart muscle with a multifactorial etiology. It's often viral, following an infection like Coxsackie virus or influenza, though it can be bacterial like diphtheria. What makes it a medico-legal trap is the timeline. The sudden death can occur days or even weeks after the main clinical symptoms of the flu have entirely passed. The person assumes they are fully recovered, goes for a jog, and suddenly collapses.
Visually, at autopsy, the pathologist might catch a subtle clue. The heart muscle can look pale, slightly hemorrhagic, or have a mottled appearance, but visual inspection is woefully insufficient for a definitive diagnosis. It requires extensive microscopic sampling at post-mortem. The pathologist must examine multiple sections of the myocardium under the lens to confirm the presence of multifocal inflammatory cell infiltrates, typically lymphocytes in viral cases, and prove that these inflammatory cells are actively causing necrosis or destruction of the adjacent myocytes.
Moving to the cardiomyopathies, these present a different kind of threat because they are largely familial, genetic conditions. The textbook notes they typically follow an autosomal dominant inheritance pattern. This makes the forensic autopsy incredibly important, not just for establishing the cause of death for the deceased, but for identifying a genetic time bomb that might be ticking within surviving family members. The source material highlights 3 major types.
The first is hypertrophic cardiomyopathy, or HCM. This is an inherited disease driven by mutations in the genes encoding the sarcomeric proteins. Those are the fundamental contractile units of the heart muscle. The heart wall becomes massively thickened, often asymmetrically. Under the microscope, the defining feature is myocyte disarray.
It's just chaotic.
Extremely. Instead of the muscle fibers lining up in neat, parallel, highly efficient rows, they are tangled, branching, and chaotic, interspersed with heavy fibrosis. This structural chaos provides an ideal substrate for lethal electrical reentry circuits.
The second type is dilated cardiomyopathy, or DCM. The heart becomes enlarged, but instead of being thick and muscular, the walls are stretched, weak, and floppy. It loses its contractile force. While DCM can be a primary genetic disorder, it is very often a secondary phenomenon resulting from an external toxin, with chronic, severe alcohol misuse being a classic etiology.
And the third type is a classic hallmark of forensic pathology: arrhythmogenic right ventricular cardiomyopathy, or ARVCM. The pattern recognition here is highly specific. It is characterized by the progressive fibrofatty replacement of the myocardium, predominantly targeted at the right ventricle. The healthy, functional muscle tissue is gradually destroyed and literally replaced by adipose fat and scar tissue. This structurally ravages the electrical pathways on the right side of the heart, predisposing the patient to life-threatening ventricular arrhythmias. It is frequently the underlying cause when young, otherwise healthy athletes die suddenly on the field.
Which brings us to perhaps the most chilling category of sudden cardiac death. What happens when a young, seemingly healthy person dies suddenly? The forensic pathologist does a meticulous autopsy, dissects the coronary arteries, weighs the heart, looks extensively under the microscope, and finds absolutely nothing. The structural architecture is perfect. There is no inflammation, no plaque, no fibrofatty replacement.
This scenario forces us to look at the invisible killers, the channelopathies. These conditions account for roughly 4% of all sudden cardiac deaths involving ventricular tachyarrhythmias. Pathologically, there are 0 macroscopic or microscopic abnormalities to find. The lethal defect exists entirely at the molecular level.
We are talking about the genes that code for the ion channels on the cellular membranes, the sodium, potassium, and calcium channels that orchestrate the flow of electricity, action potential by action potential.
Mutations in these specific genes or defects in the ryanodine receptors responsible for intracellular calcium homeostasis fundamentally alter the electrical action potential of the heart. They create abnormal depolarization and repolarization gradients across the myocardium, triggering lethal arrhythmias in a heart that otherwise looks pristine. We are referring to conditions like Wolff-Parkinson-White, long QT syndrome, Brugada syndrome, and catecholaminergic polymorphic ventricular tachycardia.
Because these defects are utterly invisible to the traditional tools of the scalpel and the microscope, how does modern forensic medicine adapt? You can't photograph a mutated potassium channel during a gross autopsy.
It requires a complete paradigm shift in forensic practice, shifting from anatomical pathology to molecular pathology. The Swiss Society of Legal Medicine has laid out vital, standardized recommendations for this exact scenario. They mandate a comprehensive forensic autopsy for all sudden cardiac death victims under the age of 40. Crucially, during that autopsy, the pathologist must collect and properly store adequate tissue samples specifically for molecular and genetic testing.
You have to extract the DNA.
You simply cannot diagnose a channelopathy without extracting the DNA. Furthermore, the medical legal system must facilitate a multidisciplinary approach. The forensic findings must be communicated to clinical cardiogenetic counselors to initiate cascade screening for surviving first-degree relatives. The autopsy of the deceased quite literally becomes the key to preventing the sudden death of their siblings or children.
It's an incredible evolution of the field. Let's shift our focus away from the heart and move to the major vasculature. We're looking at weakened walls, specifically aneurysms and dissections. Returning to our plumbing metaphor, when pipes age, endure high pressure, and suffer structural damage, they bulge. In the human body, where is the most common location to find these bulging pipes, these atheromatous aneurysms?
The abdominal aorta is overwhelmingly the most common site. These abdominal aortic aneurysms, or AAAs, are a frequent finding in the elderly population, with prevalence estimates ranging from 1 to 12%, depending on the demographic. The pathogenesis is inextricably linked to the atheromatous plaques we discussed earlier. The severe plaque formation physically damages the underlying elastic component of the aortic wall, the tunica media. Without that crucial elasticity to absorb the pulse wave, the unrelenting systemic blood pressure causes the weakened wall to stretch and balloon outward.
These aneurysms can take different anatomical shapes. They can be saccular, resembling a distinct pouch bulging off one side of the vessel, or fusiform, where the entire circumference of the vessel stretches out like a swollen cylinder. The walls become paper-thin, often brittle with calcification, and internally lined with thick, laminated layers of old, organizing blood clots. Many individuals live with them for years as incidental, asymptomatic findings. But when that compromised wall finally gives way, the clinical outcome is catastrophic.
Even if the rupture occurs while the patient is already in a hospital and they are rushed to an operating room for endovascular stenting or an open surgical repair, the mortality rate remains staggeringly high, often between 20 and 40%. The volume of blood loss is simply too rapid.
When an abdominal aortic aneurysm ruptures, where does all that blood actually go?
Because the aorta is positioned in the retroperitoneal space, the anatomical compartment behind the main abdominal cavity, the massive hemorrhage typically fills that retroperitoneal area first. The bleeding tracks along the tissue planes. It can track laterally and completely envelop a kidney in a massive, solid hematoma. Sometimes, the pressure of the bleeding or the aneurysm itself will burst through the posterior peritoneum, causing a hemoperitoneum, where liters of blood rapidly fill the main abdominal cavity, leading to fatal hemorrhagic shock in minutes.
So that describes a true aneurysm, a full-thickness ballooning of the wall. But how does a dissecting aneurysm differ? The terminology implies something much more aggressive and mechanically destructive.
A dissection is a fundamentally different biomechanical failure. In an aortic dissection, an atheromatous plaque, a spike in blood pressure, or a structural weakness causes a focal defect, a tear in the innermost layer of the artery, the intima. This intimal tear exposes the middle muscular layer, the media, which is often already degenerated. The highly pressurized blood from the main lumen forces its way into that tear and acts like a wedge, literally splitting or dissecting the layers of the arterial wall apart.
The blood creates a completely new, false channel inside the wall of the pipe itself. And once that dissection initiates, the sheer hydraulic pressure of the heart pumping drives it forward relentlessly. It most commonly originates in the thoracic aorta, up near the heart where the pressure is highest. From there, it typically tracks distally, shearing its way down the aorta into the abdomen, sometimes spiraling all the way down to the iliac or femoral arteries in the legs.
The collateral damage as it tracks downward is immense. If the dissection plane shears across the origins of the renal arteries, it instantly chokes off the blood supply to the kidneys, causing acute renal failure. If it shears across the mesenteric arteries, it causes catastrophic bowel ischemia.
And it can rupture completely out of the outer wall at any point along that path, causing massive internal bleeding. We mentioned it usually tracks distally down the body, but the source material highlights a rapidly fatal scenario if it tracks proximally back towards the source of the pressure.
If the dissection tracks proximally around the arch of the aorta, it can dissect right back to the root of the aorta and rupture directly into the pericardial sac. Just like we discussed with the ruptured myocardial infarction, this immediately causes a massive hemopericardium, acute cardiac tamponade, and sudden death.
Who typically suffers from these dissections? It seems like it requires an immense amount of pressure to split an artery lengthwise.
We generally see two distinct demographic profiles. Principally, it is older individuals with a long-standing history of severe hypertension. The chronic high blood pressure provides the mechanical shearing force necessary to tear the weakened wall. However, we also see this exact pathology in much younger individuals who suffer from connective tissue disorders, the classic example being Marfan syndrome. In these younger patients, the underlying issue is cystic medial degeneration. The structural integrity of the arterial wall, specifically the fibrillin proteins, is genetically faulty from birth. Their aorta can dissect even at normal blood pressures.
For the sake of comprehensive historical context, the text mentions one rare but medically fascinating cause of aneurysms that used to fill forensic textbooks: syphilis.
Syphilitic aneurysms are incredibly rare today in the developed world due to the advent of antibiotics like penicillin, but they must always be considered in the differential diagnosis, especially in elderly populations or individuals migrating from areas lacking robust healthcare infrastructure. The underlying mechanism is fascinating. The bacteria responsible for syphilis, Treponema pallidum, actually invades the wall of the aorta itself.
It sets up shop in the vas of Asorum, the tiny network of blood vessels that supply oxygen to the thick tissues of the aorta. The body's immune system mounts a fierce inflammatory response against the bacteria, which inadvertently progresses to obliterative endarteritis, essentially scarring and choking off those tiny feeding vessels.
The aortic wall slowly dies from a lack of its own blood supply. This causes extensive necrosis of the muscular and elastic fibers in the tunica media. The inner surface of the aorta takes on a classic wrinkled tree bark appearance. These syphilitic aneurysms overwhelmingly target the thoracic aorta, specifically the arch. As the wall becomes paper-thin and loses all elasticity, it leads to massive dilation of the aortic root, severe insufficiency of the aortic valve leading to heart failure, and eventually a massive fatal rupture into the chest cavity.
It is incredible how a microscopic spearhead can dismantle the largest artery in the body. Let's travel north from the chest and enter the cranial cavity. We are entering a medico-legal minefield here. Let's start with Berry aneurysms.
Berry aneurysms, also known as saccular aneurysms, are a relatively common cause of sudden collapse and rapid death, particularly striking young to middle-aged adults. They occur in the basal cerebral arteries, either located directly on the circle of Willis at the base of the brain or on the major supplying arteries. They tend to form at the bifurcation points of these vessels, where the hemodynamic stress is greatest. Current estimates suggest about 1 to 2% of the general population walks around with one or more of these tiny vascular weaknesses.
They are usually minuscule, just a few millimeters across, though some can grow much larger. They're essentially tiny bubbles on the side of the blood vessel. If one of these bubbles bursts, what exactly happens inside the skull?
The rupture leads immediately to a subarachnoid hemorrhage. Arterial blood under high pressure floods the subarachnoid space at the base of the brain and can sometimes jet directly into the adjacent brain parenchyma itself. The precise mechanism of sudden death in these cases is complex. It is likely a devastating combination of the rapidly expanding blood volume directly compressing the brainstem, which houses the vital cardiorespiratory control centers, combined with the irritating presence of the blood invoking severe, widespread vascular spasm, which further stars those critical brainstem centers of oxygen.
Okay, let's build a scenario to explore the core criminal controversy the source material highlights regarding Berry aneurysms. The altercation scenario. Two individuals are at a pub. A heated argument breaks out. There's aggressive shouting, intense emotional stress, maybe some shoving back and forth, but witnesses confirm there's absolutely no physical evidence of blunt force trauma to the head. No punches land. Suddenly, one of the individuals clutches their head, collapses, and dies before the paramedics arrive. The autopsy reveals a ruptured Berry aneurysm and a massive subarachnoid hemorrhage. The medical legal question that will consume the courtroom is, did the argument cause the death?
This is a classic, deeply contested dilemma in forensic pathology. The prosecution will build a case arguing that the intense emotional stress, anger, and physical exertion of the altercation caused a massive transient spike in catecholamines and blood pressure. They will argue that this acute hypertensive spike is what pushed the pre-existing weakened aneurysm past its breaking point. Therefore, the defendant's aggressive actions directly triggered the fatal rupture.
But the defense will counter with the statistical reality of these lesions. They will argue that Berry aneurysms rupture spontaneously all the time, completely at random. People die from them while sleeping peacefully in bed or sitting quietly reading a book.
Exactly the forensic challenge. Proving definitive causation beyond a reasonable doubt when there is absolutely no physical trauma is incredibly difficult. Furthermore, in many of these scenarios, the deceased may have been consuming alcohol or illicit stimulants, which independently elevate blood pressure and alter vascular tone. Untangling the emotional stress of the argument from the pharmacological effects of the alcohol and the natural history of a spontaneous rupture is a matter of intense, often protracted debate in criminal courts. The pathologist must be extremely careful with their wording, often testifying that the altercation could have precipitated the rupture rather than stating it as an absolute certainty.
Now, we must contrast that ambiguous stress-induced rupture with a purely traumatic basal subarachnoid hemorrhage. The end result looks somewhat similar, but the mechanism is a completely different beast.
In traumatic basal subarachnoid hemorrhage, the mechanism is entirely physical and biomechanical. The classic scenario involves an individual very often intoxicated, which sluggishes their protective neck muscle reflexes, sustaining a blow to the side of the head or the neck. The actual impact doesn't necessarily need to be severe enough to fracture the skull. The danger lies in the kinematics. The blow causes a rapid extension and violent, severe rotation of the head on the neck.
Like a violent snapping torsion.
Yes, that violent rotational force stretches and literally tears one of the major intracranial blood vessels. Because of its anatomical path, ascending through the bony transverse foramina of the cervical vertebrae before entering the skull, the vertebral artery is overwhelmingly the most common vessel to be torn in this mechanism. The tear results in a massive basal subarachnoid hemorrhage and a remarkably rapid cardiac arrest, often much faster than a spontaneous Berry aneurysm rupture.
But if a body arrives on your table with a subarachnoid hemorrhage, and you know they just got punched in a bar fight, how do you scientifically prove it was a traumatic tear of the vertebral artery and not just a spontaneous Berry aneurysm that coincidentally happened to burst the moment they got hit?
That differentiation requires the utmost rigorous forensic discipline. The defense attorney will immediately seize on the possibility of a coincidental spontaneous rupture. You have to definitively prove the arterial defect is traumatic. You cannot simply remove the brain using standard autopsy techniques, as the traction involved in pulling the brain out of the skull can easily tear the delicate basal arteries, creating a post-mortem artifact that looks identical to the trauma you are trying to prove.
So how is it done?
It requires meticulous in situ dissection. The pathologist must carefully dissect and examine the vertebral and basilar arteries while they are still situated in the base of the skull. This is frequently done under an operating microscope. You must clearly demonstrate the physical traumatic tear in the vessel wall and then confirm histologically under the microscope that there is absolutely no intrinsic vascular abnormality, like an underlying Berry aneurysm or atheroma present at the exact site of the rupture. Meticulous discipline and photographic documentation are the only ways to establish the truth for the court.
Before we leave the brain, let's briefly touch on cerebrovascular lesions, commonly known to the public as strokes. While we think of them as clinical events, they frequently cross over into the forensic realm as unexpected deaths.
Spontaneous intracerebral hemorrhage is typically found in older individuals with a significant history of systemic hypertension. The catastrophic bleeding most often occurs deep within the brain structures, specifically in the basal ganglia, or the external capsule. Pathologically, this hemorrhage usually arises from the rupture of tiny microaneurysms situated on the lenticulostriate artery, a deep penetrating branch of the middle cerebral artery. Historically, these specific vascular defects were known as Charcot-Bouchard aneurysms.
When these deep microaneurysms rupture, the resulting hematoma physically tears through and destroys the surrounding delicate brain tissue. It frequently obliterates the internal capsule, the major superhighway of motor fibers descending from the cortex, leading to the classic clinical presentation of hemiplegia, or dense paralysis on one side of the body.
While death from a stroke isn't always sudden, patients often survive for days or weeks in a coma. It is a critical forensic consideration. Furthermore, the source material points out the complex autonomic nervous system links between the brain and the heart. A massive sudden hemorrhage in the brain can flood the system with catecholamines and precipitate a fatal cardiac arrhythmia. In these cases, a primary cerebrovascular event masquerades as a sudden cardiac arrest.
Moving down from the cranial vault, let's explore the respiratory and gastrointestinal traps that catch both clinicians and forensic pathologists off guard. Let's start with the lungs. We have to talk about pulmonary embolism, or PE. The textbook labels this as the third most common life-threatening cardiovascular condition, and notably, it is highly underdiagnosed clinically.
It is a massive, often silent killer. The pathological pathway almost always begins far away from the lungs themselves, typically down in the deep veins of the legs, the calves, or the pelvis. Blood flow slows down, pooling occurs, and a deep vein thrombosis, or DVT, forms. If a piece of that unstable thrombus breaks off, it becomes a thromboembolus. It travels freely up the venous system through the inferior vena cava, passes through the right atrium and right ventricle of the heart, and gets pumped directly into the pulmonary arterial tree.
Where the vessels are branching and getting progressively smaller, the clot acts like a cork plunging into a bottleneck.
If the clot is massive, what we call a saddle embolus, that lodges right at the main bifurcation of the pulmonary trunk, it physically blocks blood flow to both lungs simultaneously. This causes acute, massive right heart strain as the right ventricle pushes against an immovable blockage, leading to immediate mechanical heart failure and sudden death. If the emboli are smaller, they travel deeper into the peripheral pulmonary arteries, blocking smaller regional vessels. This causes localized pulmonary ischemia and infarction, which can reflexively trigger a fatal cardiac arrest.
The intersection of pathology and the legal system here is fascinating, especially regarding the long-term consequences of trauma. Let's trace the causal link. A person is involved in a car accident or sustains a severe fracture. The trauma requires prolonged immobility, perhaps weeks of bed rest or a cast. That immobility leads to venous stasis and the formation of DVT. Weeks later, as they are recovering, the DVT breaks off and causes a fatal PE. The intense legal question becomes, is the person who caused the initial car accident legally responsible for the death from the pulmonary embolism a month later?
This scenario perfectly illustrates the differing standards of proof in the legal system. In a civil lawsuit for wrongful death, the standard of proof is the balance of probabilities. It is relatively easier for a pathologist to convince a civil court that it is more likely than not that the trauma led to the immobility, which led to the DVT, which caused the PE. The chain of causation holds up. But in a criminal court, perhaps facing a charge of manslaughter, the standard is beyond a reasonable doubt. Because asymptomatic DVTs and fatal pulmonary embolisms can and do happen spontaneously in completely normal ambulant people without any preceding trauma, proving that specific unbroken criminal link beyond a reasonable doubt is a remarkably high hurdle. The defense will always introduce the possibility of a spontaneous, unrelated clot.
Let's pivot to the gastrointestinal system. We don't often think of the gut when discussing sudden death. But how do GI emergencies present to the forensic system?
GI fatalities usually present to the coroner or medical examiner due to delayed medical intervention. They are essentially massive vascular or septic catastrophes hidden within the abdomen. For example, a chronic peptic ulcer in the stomach or duodenum can quietly erode through the mucosal wall. If it hits a major artery, it leads to massive upper GI bleeding. If it perforates completely through the bowel wall, acidic stomach contents flood the sterile abdominal cavity, causing overwhelming, rapidly fatal peritonitis.
Another classic GI vascular disaster relates to liver disease. If a patient has portal hypertension, most commonly resulting from severe liver cirrhosis, the blood struggling to filter through the scarred liver backs up. It seeks alternative collateral routes back to the heart. This high pressure engorges the fragile veins in the lower esophagus, creating esophageal varices. These varices are incredibly thin-walled. If they rupture, the patient can literally bleed to death internally within minutes, often presenting as a sudden collapse with massive hematemesis or vomiting of blood.
We also encounter mesenteric ischemia or thrombosis, where the vital arterial blood supply to the intestines suddenly clots off, often due to atheroma. The affected segment of bowel rapidly undergoes infarction and necrosis, leaking toxins and bacteria into the bloodstream, leading to profound septic shock. Similarly, a strangulated hernia where a loop of intestine gets trapped in a muscular defect in the abdominal wall swells and loses its venous drainage and arterial supply will quickly become gangrenous. If an elderly person lives alone, experiences these catastrophic internal events, and fails to seek help in time, they present to the forensic system days later as a sudden, unexpected death that requires an autopsy to uncover the hidden abdominal disaster.
This perfectly transitions us to our final major grouping of specific pathologies. We need to look at gynecological conditions, the forensic approach to asthma, and the complexities of epilepsy. Let's start with a hard, unwavering rule in forensic pathology regarding the autopsy of female decedents.
The rule is absolute and taught on day one. In any deceased female of childbearing age, complications of pregnancy must be considered as the primary working hypothesis for the cause of death until it is definitively excluded by autopsy dissection and biochemical testing. You cannot make assumptions based on medical history, social status, or external appearances.
What are the major acute gynecological risks that lead to rapid death outside of a hospital setting?
Ectopic pregnancies are a critical, high-stakes forensic finding. If an embryo implants outside the uterus, most commonly within the narrow confines of the fallopian tube, the growing trophoblastic tissue will eventually stretch and erode the highly vascular tube wall. When the tube inevitably ruptures, it severs major arteries. This leads to massive, often catastrophic intra-abdominal hemorrhage. If the woman is at home and unaware of the ectopic pregnancy, the internal bleeding is rapidly fatal and the autopsy will reveal a massive hemoperitoneum.
The source material also provides a specific medical legal framework for classifying maternal deaths. By definition, these are deaths occurring during pregnancy or within 12 months of delivery or termination. How does the system categorize these tragedies?
They are meticulously divided into 3 categories for epidemiological tracking. Direct maternal deaths are those caused by diseases or complications specifically unique to the physiological state of pregnancy. Examples include severe preeclampsia leading to eclamptic seizures, amniotic fluid embolisms where fetal material enters the maternal circulation, or massive postpartum obstetric hemorrhage. Indirect maternal deaths are caused by pre-existing underlying conditions that were fatally exacerbated by the immense physiological and hemodynamic stress that pregnancy places on the body. For instance, a woman with a pre-existing undiagnosed cardiomyopathy or valvular heart disease that fails under the increased blood volume demands. Finally, coincidental deaths are those entirely unrelated to the pregnancy itself, such as a pregnant woman tragically dying in a motor vehicle collision.
Moving to the respiratory system, let's discuss asthma. We view asthma as a manageable chronic condition, but forensically, it can turn suddenly violently fatal.
Acute fatal asthma attacks, often termed status asthmaticus, can certainly be triggered by common environmental allergens or respiratory infections. But forensically, we must actively investigate illicit triggers. Abused drugs, specifically heroin and the inhalation of smoked crack cocaine, are notable culprits for precipitating a sudden, overwhelming bronchospasm. When you perform an autopsy on a fatal asthma case, the gross pattern recognition is striking. When you remove the chest plate, the lungs are massively hyperinflated. They remain fully expanded and literally bulge out of the chest cavity, failing to collapse. They look remarkably similar to the emphysema aquosum we observe in drowning victims.
The lungs trap the air. The severe bronchospasm and mucus plugging act like one-way valves, The person can forcefully inhale air into the alveoli, but the narrowed airways prevent them from exhaling it. They essentially suffocate, despite having lungs full of oxygen.
Exactly. When you dissect the bronchi, the airways are plugged with thick, incredibly tenacious mucus casts. Under the microscope, the chronic pathology is evident. You see extensive airway remodeling, massively thickened basement membranes underlying the epithelium, a prominent overgrowth of bronchial smooth muscle and mucus-secreting goblet cells, and a heavy inflammatory infiltrate heavily characterized by eosinophils. Furthermore, if the pathologist suspects that a sudden anaphylactic reaction was a primary component of the fatal attack, they can secure a post-mortem blood sample to test for elevated levels of mast cell tryptase, which provides biochemical confirmation of a massive allergic cascade.
Finally, we arrive at one of the most enigmatic phenomena in forensic medicine: SEAP, or sudden unexpected death in epilepsy. Define the strict parameters of this classification.
SUDEB is not a catch-all term. It is a very rigid, specific classification. It is defined as a sudden, unexpected, witnessed or unwitnessed, non-traumatic and non-drowning death occurring in a patient with a known history of epilepsy. Crucially, there must be no toxicological cause, meaning comprehensive toxicology confirms they didn't suffer an overdose of their anti-epileptic medication or illicit drugs, and there must be no documented evidence of status epilepticus, which is a prolonged, clinically observable, unending seizure.
So, logically, it is fundamentally a diagnosis of exclusion. You have to exhaustively rule out every other conceivable anatomical or chemical cause of death first. You can't just glance at a medical chart, see a history of seizures, and sign off.
Absolutely not. A comprehensive, detailed neuropathological examination of the brain is absolutely mandatory. The brain must be properly fixed, sectioned, and examined microscopically to ensure there is no hidden pathology, like a slow-growing glial tumor, evidence of old traumatic brain injury causing a seizure focus, or a cryptic arteriovenous malformation that suffered a fatal microscopic hemorrhage. Only when the gross anatomy, the microscopic histology, and the comprehensive toxicology are completely clear can a pathologist invoke SUDA as the official cause of death.
But if there is absolutely no anatomical or toxicological cause to point to, what is the actual physiological mechanism killing the patient during these SUD events?
The precise mechanism remains highly theoretical, heavily debated, and is likely multifactorial. Current neurological research suggests the lethal event may be a seizure-induced fatal cardiac arrhythmia mediated by a massive surge of autonomic nervous system activity during the electrical storm in the brain. Alternatively, the seizure activity may spread down into the brainstem and cause profound central inhibition of the respiratory control centers, essentially turning off the body's innate drive to breathe, leading to lethal hypoxia. But at autopsy, the physical findings are entirely nonspecific. The pathologist typically only finds general venous congestion and severe pulmonary edema. It remains one of the great frustrating mysteries in modern forensic pathology.
So it all comes back to rigorous elimination.
To synthesize this entire chapter, the fundamental theme that every forensic pathologist must internalize is this: the absence of external injury never equals the absence of a cause. You have to rigorously untangle the sequence of events. You must clinically differentiate the underlying disease causing the death from the physiological mechanism of dying. For example, cardiac arrest is merely a mechanism. Every human being's heart stops when they die. Writing cardiac arrest on a death certificate provides no information. The forensic question is always, why did the heart stop? Was it an ischemic arrhythmia driven by a ruptured atheromatous plaque, a massively enlarged left ventricle from aortic stenosis, a saddle pulmonary embolus blocking the outflow tract, or a completely invisible molecular channel defect? Certainty in forensic medicine comes only from meticulous, disciplined investigation and the systematic, scientific exclusion of all alternative explanations.
I want to leave you with a thought that really shifts the paradigm of everything we've just discussed. We spent this whole time talking about what happens when the body's internal systems fail and how forensic pathologists reconstruct that timeline in the dark using a scalpel, a microscope, and historical context. But what happens when the timeline is already digitally recorded? I'm talking about the explosion of wearable tech. Smartwatches, continuous glucose monitors, implanted cardiac defibrillators that log every heartbeat.
It is rapidly becoming the new frontier. We are moving from retrospective anatomical reconstruction to analyzing prospectively recorded digital telemetry.
If an Apple Watch records the exact millisecond a fatal ventricular arrhythmia begins and tracks the declining oxygen saturation until the pulse stops entirely, does the traditional forensic autopsy become secondary? In 10 years, will forensic pathologists spend more time analyzing digital data logs from the cloud than they do looking at tissue slides under a microscope? It completely redefines the concept of the silent natural death.
A fascinating prospect, and one the medical legal system is currently scrambling to integrate into the standard of proof.
Before we wrap up, let's lock in some of the highest yield concepts for anyone using this to study. If I throw a few rapid-fire scenarios at you, can we build a quick recall session?
I think that is a fantastic way to consolidate the material. Let's do it.
All right, listener, play along with us. Think back to the very beginning. We talked about the WHO definition of sudden death timeframe and compared it to our forensic definition. Clinical guidelines give a much wider berth for that terminology. Question 1. What is the WHO definition of sudden death timeframe compared to the forensic definition?
Right. The WHO allows for a clinical diagnosis within a 24-hour window from the onset of symptoms. But in our forensic world, we are dealing with rapid catastrophes. The definition demands minutes, or at most, seconds.
Perfect. Now let's think about the ischemic cascade. A patient survives a massive myocardial infarction. A portion of their heart muscle dies. But there's a secondary time bomb regarding physical rupture and cardiac tamponade. Question 2. Following a myocardial infarction, what is the peak time window of risk for myocardial rupture and subsequent cardiac tamponade?
You are looking at the time frame when the macrophage cleanup operation peaks, turning the necrotic tissue into wet cardboard. That maximum risk window for myocardial rupture is firmly between 3 days and 1 week post-infarct.
Let's test differentiation on the autopsy table. You weigh a heart, and it's 450 grams. It shows isolated left ventricular hypertrophy. But when you look under the microscope, there is absolutely no interstitial fibrosis between the myocytes. Question 3. Is this more likely a consequence of hypertension or a physiological adaptation in an athlete?
The key differentiator is the lack of scar tissue. Without that pathological fibrosis, you are looking at a healthy physiological adaptation. That is an athlete's heart.
Now, a tragic scenario. A young athlete collapses and dies on the field. You do a meticulous autopsy, and the heart is structurally flawless. No hypertrophy, no ARVCM fibrofatty replacement. Question 4. What invisible category of disease must be investigated, and how?
You must suspect the channelopathies, the genetic molecular defects in the ion channels. The protocol mandates the retention of tissue for DNA extraction and molecular testing, followed by vital cascade genetic screening for the surviving family members.
Moving to the abdomen. A patient dies rapidly from massive intra-abdominal hemorrhage. You find an atheromatous aneurysm has ruptured. Question 5. Where is the most likely location of this atheromatous aneurysm?
The vast majority of these bulging defects are found in the abdominal aorta, typically bleeding out into the retroperitoneal space.
Question 6. Autopsy of a sudden death victim reveals fibrofatty replacement of the right ventricular myocardium. What is the diagnosis?
That specific pattern is arrhythmogenic right ventricular cardiomyopathy, or ARVCM.
Let's jump to the brain for our final question. We contrasted spontaneous Barry aneurysms with physical trauma. In a traumatic basal subarachnoid hemorrhage, say, from a violent punch that rapidly rotates the head and neck. Question 7. What specific blood vessel is most kindly stretched and torn?
Because of its vulnerable anatomical path through the cervical vertebrae before entering the skull, the vertebral artery is the most frequent casualty of that violent rotational force.
Congratulations on making it through this dense, crucial material. Remember, this analysis is a conceptual framework designed to clarify mechanisms. You must revisit Chapter 6 of Simpson's Forensic Medicine to consolidate these details, review the specific medical legal wording, and study the gross and microscopic images. Until next time, keep questioning the surface and keep looking deeper.